A common criticism or misconception about how clinicians like myself treat patients using Robin McKenzie's concepts of repeated movement testing and repeated directional preference movement for patients with joint derangements is that we only give patients extension, spine extension, neck extension or low back, shoulder extension or knee extension, and that's absolutely not the case. We may or likely use repeated extension as a test for the majority of patients, and that's because it's one of the starting places for repeated movement testing and because of prevalence. It's like asking a clinician if they're always testing the thyroid for complaints of fatigue. It can be a common source of complaints of fatigue, so most clinicians will go there. So for people like myself who use repeated movement testing as an orthopedic test for most patients, yes, I am testing extension for many patients, most patients, not just in the spine, but in the extremity joints as well. And that testing often takes place over the course of several days at home. But when it comes to the actual repeated movement that fixes most disorders, there are other movements besides extension. Many patients in the neck need rotation or side bend. Patients with thoracic spine joint derangements may need rotation. Patients with hip complaints may need internal rotation or external rotation. It runs the gamut. For example, I do not do well with lots of extension through my low back. If you were to ask me to do 6 sets of 10 extensions throughout the day for many days into my low back, I would likely get considerably or mildly worse. The directional preference for my low back to untweak the joint and get everything moving and feeling better is flexion and rotation with my legs to the right. So there are unique differences for different patients, and there are different movements that untweak joints, so to speak, and get them back on track, abolishing signs and symptoms. Again, not everybody has a joint derangement that's mechanical in nature as their diagnosis, but I find that most people do, and I find that when they go to other clinicians, they're getting misdiagnosed because clinicians do not understand the concept of testing for mechanical problems. Imaging and quick orthopedic special tests largely focus on structure and not mechanics, not function of joints. So I don't really have an extension bias. I may have started with one when I was more of a novice, but just knowing myself that if I do a lot of extension in my low back, I'll get worse, helps me to keep in mind that extension is not a panacea. Yes, when it comes to the spine, most patients with mechanical problems need some form of extension, but we can get into nuance. Is it extension in weight bearing or non-weight bearing? With force, repeated, or sustained? But outside of the majority of patients who get better with extension, there are patients who need other things. And the clinician's job is to figure out what is the movement that restores the joint to normal, again, abolishing signs and symptoms, and have the patient do that motion on a regular basis.